Drugs used for cough. These are the categories of the drugs which are used for cough. First is pharyngeal demulcents, second is expectorants, third is antitussives, and fourth is bronchodilators. The expectorants are divided into two categories: bronchial secretion enhancers and mucolytics. Antitussives are divided into three: opioid, non-opioid, and antihistaminics. So first category is pharyngeal demulcents. These soothes the throat, the pharynx, thereby relieving the pharyngeal irritations. Example: glycerin, menthol, mucorese, honey, lozenges. Second type of drugs are expectorants. Expectorants are of two types. First is secretion enhancers and second is mucolytics. Secretion enhancers increases the secretion. The mucus secretion are increased by these drugs. Example: potassium citrate, potassium iodide, guaifenesin, and Vasaka. Vasaka is Vasa, Vasatoda the Vasa, the Adatoda vesica, and the ammonium chloride. Second is the mucolytics. The expectorants, which are mucolytics. Mucolytics are the drugs which break down the thick mucus so that it can easily be expelled out by coughing. The drugs are acetylcysteine, ambroxol, and bromhexine. Third category of drugs which are used for cough are antitussives. These antitussives are the drugs which depresses the cough center, thereby relieving the cough, decreasing the cough. These are of three types: opioid antitussives, non-opioid antitussives, and antihistaminic antitussives. Opioid antitussives, example codeine. This codeine is banned nowadays because of its addiction properties. It is derived from morphine, it is methyl morphine, so it is banned. Non-opioid antitussives do not cause any addiction, thereby they are used these days. Example: dextromethorphan. Antihistaminic antitussives are those antitussives which are basically antihistaminic, and because of the side effect of these antihistaminic, that is sedation or CNS depression, they are used as antitussives. So these are chlorpheniramine, most commonly and widely used. Second is diphenhydramine, and third is promethazine. Then for cough, the cough formulas for productive cough, that is the cough with sputum, and dry cough is different. So for productive cough, the formula is generally the expectorant and the bronchodilators are mixed. Bronchodilators are explained in the later slides. So expectorants, for example, Tusk QX, Tusk X. This Tusk X contains expectorants, one that is secretion enhancer and mucolytic drug, and one bronchodilator. So example: terbutaline, ambroxol is a mucolytic drug, guaifenesin is a secretion enhancer. Similarly, this McQuarrie Jr. syrup, this is guaifenesin, ambroxol, and levosalbutamol. Levosalbutamol is a bronchodilator. For dry cough, generally this formula is used: antitussive and sedative antihistaminic, because we need to suppress the cough which is not doing its purpose to expel the mucus, so we need to suppress it. So we use both antitussives and sedative antihistaminics. Right? Sedative antihistaminics also work as antitussives. So, example: dextromethorphan plus chlorpheniramine. It is also known by CPM. So dextromethorphan and chlorpheniramine. Right? Phenylephrine is also added to few syrups. For example, Tusk DX. Here D represents dry cough, or here also it is written for dry cough. So what are the drugs used for asthma? For asthma, we have these categories of drugs: bronchodilators, corticosteroids, leukotriene antagonists, mast cell stabilizers, and anti-IgE antibodies. The bronchodilators are again divided into three categories: sympathomimetics, parasympatholytics, and methylxanthines. Corticosteroids are divided into ICS and OCS, inhaled corticosteroids and oral corticosteroids. So first, let us know how these drugs are given in respiratory system. Obviously, per oral and injection routes are there. Apart from this, inhaler route is also there to make the drug to reach to the respiratory system. So these inhalers are of three categories. Number one is meter dose inhalers. In these meter dose inhalers, this pressurized pump is there, which is used by the patient. excuse me. And the second is dry powder inhaler. In this small capsule which contains the drug in the form of dry powder is there. And third is nebulizers. The liquid solution is there. In this liquid, the drugs is dissolved, and this liquid is taken with the help of a nebulizer. So we uses these inhalers, these different three type of inhalers for respiratory drugs. So these bronchodilators, they dilates the bronchioles. So how do they do that? First is sympathomimetic category. Sympathomimetic, they mimics the sympathetic nervous system. So by mimicking the sympathetic nervous system and by being agonist to the beta receptors, they dilates the bronchioles. So these sympathomimetics, mimetics means like sympathetic neurotransmitters, right? They mimics these sympathetic neurotransmitters. So they are of two types, SABA and LABA, short acting beta agonists. Beta is the receptor name and agonist refers to the agent which are doing the same work as that of the normal neurotransmitter. So they are agonists. Opposite to agonist is antagonist. So SABA and LABA, long acting means they last long for 6 to 8 hours. Short acting means they last short 4 to 6 hours, like that. So first is short acting beta agonist, SABA. SABA, generally these two drugs are used more oftenly. First is salbutamol and second is terbutaline. Salbutamol is also given per oral route, injection route and inhaler route. Similarly, terbutaline is per oral, injection and inhaler route. Second category is long-acting beta agonist. These are roles, all the roles, salmeterol and formoterol. So these are given via the inhaler route. This is a dry powder inhaler device. In this, from here the capsule is inserted, and from here the patient puts his mouth around this opening and inhales the contents of that capsule. Second category is parasympatholytics. So these parasympatholytics, since the word lytic is there, so they are working opposite to the parasympathetic nervous system. The parasympathetic nervous system normally constricts the bronchiole. So we are giving drugs which are opposite to the neurotransmitters of the parasympathetic nervous system, thereby they dilates the bronchioles. They are also of two types, short-acting anti-muscarinic agents. Muscarinic is the receptor name. Anti to that receptors, it blocks the receptors. Second is long-acting anti-muscarinic agents, LAMAs. So SAMAs, first is SAMAs. SAMAs is ipratropium bromide, and second is LAMA. LAMA is tiotropium bromide. The next category of bronchodilators are methyl synthase. These are derived from plant metabolites. For example, from caffeine plants we derive these, theophylline and theobromine. Theophylline group is most commonly used. These are aminophylline, etophylline, theophylline, doxophylline, acebrophylline. So these are aminophylline. These are used as tablets per oral route, and they dilates the bronchioles, thereby relieving the dyspnea. In combination, we use drugs. For example, we mixes both short-acting beta agonist and short-acting anti-muscarinic agents, SABA and SAMA. For example, salbutamol is ipratropium bromide, commonly comes as duolin respules from Cipla. These duolin respules are very commonly used. LABA and LAMA. For example, formoterol is a LAMA. Formoterol is a LABA, and tiotropium bromide is a LAMA. So in combination they are used. Another combination is SABA plus Mexa. Another combination is Mexa and Mexa. For example, etophylline and theophylline are mixed, and it is called as Darify. The trade name is Darify. Then drugs for asthma. For the second category of the drugs for asthma is corticosteroids. Corticosteroids are used in two ways. First is ICS, second is OCS. ICS is inhaled corticosteroids. Inhaled corticosteroids. So these are corticosteroids which are taken through the through the inhaling route. So beclomethasone is the first, second is budesonide. So budesonide and beclomethasone are very important. Baclate inhalers and budecort respules, budecort inhalers. Second is others are fluticasone and triamcinolone acetinoids. They are also used. Combinations of these ICS plus LABAs are very much preferred these days. For example, budesonide plus formoterol, fluticasone plus salmeterol, Other categories of the drugs which are used for asthma are leukotriene antagonists. See, these drugs are antagonists to the leukotrienes, which are the cytokines which causes the inflammation. So mast cell stabilizers, this stabilizes the mast cell so that the mast cell is not disrupted and it does not releases its content histamine and does not causes inflammation. So to stabilize the mast cell, which are the agent of inflammation. Then anti-IgE antibodies, these are the drugs which are anti to the IgE antibody, because this IgE antibody is involved in causing the allergies. So leukotriene antagonists are montelukast and zafirlukast. Mast cell stabilizer are sodium chromoglycate. Anti-IgE antibodies are omalizumab. Right? These omalizumab, they neutralize the IgE antibody, thereby preventing the allergic phenomena. Then what are the protocols for asthma management? Let us see the GINA protocols, the Global Initiative for Asthma Management protocols. So they have given two protocols. This is protocol number 1, step 1 to step 5, and this is protocol number 2, step 2 to step 5. So first protocol is preferred to all the patient, but however, if some patients are taking the this second protocol is the previous protocol which GINA used to give before 2020. So if some patient is happy, adherent to the previous protocol, and if they are doing very well with this protocol, then this protocol is can also be started or can also be continued. So what is the new protocol? The new protocol says as soon as the patient is diagnosed with asthma and the symptoms are minimal, that is 4 to 5 times per week or less than that, then immediately we have to start the patient with a long acting beta agonist, that is formoterol, and inhaled corticosteroids, right? Inhaled corticosteroid like budesonide. So budesonide and formoterol is the very common hit combination which is given as soon as the patient is diagnosed with asthma. So when the symptoms increases, we go to the next step. In next step, the ICS formoterol. In first step, the ICS formoterol is given as needed, whenever it is needed, whenever the patient is dyspneic, it is given. In step 3, it is given as a maintenance dose. That means regularly it is given, either once daily or twice daily, right? In the form of puffs, if it is MDIs, right? Mostly MDIs are given because they are easy to take. MDIs or rota caps are given. So dry powder inhalers are given, or metered dose inhalers are given. So daily, regularly they are given, once daily, twice daily, like that. In step 4, the dose is increased of ICS formoterol to medium dose. And in step 5, along with ICS formoterol, we have to add LAMA also, some long acting anti-muscarinic agents, and we have to add some anti-IgE also as per desired. The previous protocol was to start with SABA, right, short-acting beta agonist. The short-acting beta agonists were used to give it, but now they have added that with short-acting beta agonist, ICS, inhaled corticosteroid, also given along with it. So it is given as per required. In second step, it is given as a maintenance, that means daily. In third, it is given and low doses maintenance doses, and fourth step, it is given in a medium or high dose. In fifth step, other agents like anti-IgE and other anti-mast cell stabilizers are given. So this is asthma protocol. So when I say low, medium and high doses of ICS, it means low for beclomethasone is 100 to 200, medium is 200 to 400, and high is above 400. Then COPD management, the gold criteria, the gold staging, also the gold criteria also gives the treatment protocol, treatment management protocol for COPD. COPD is labeled as mild, moderate, severe and very severe. Mild is when the FEV1 is less than or equal to 80%, which is almost normal, and FEV1 and FVC ratio is less than 0.70. Moderate is when it is less than even 80% but up to 50%. Severe is when it is less than 50% up to 30%. Very severe is when the patient is less than 30% and the patient is presenting with respiratory failure symptoms as well. So in such mild, moderate, severe and very severe conditions, in mild conditions, a bronchodilator, mostly short-acting bronchodilators, for example, short-acting beta-agonists or short-acting antimuscarinic agents are used, either in the inhaler form, any of the inhaler form. Mostly in the inhaler form only, not as a oral, because these oral methylxanthines have proved to be more side effect causing, and they are not preferred nowadays. They causes some dizziness, some tachycardias, some seizures, like that. Not dizziness, seizures and tachycardias. Then in moderate conditions, along with this short-acting bronchodilators, we use some long-acting bronchodilators also. For example, LABAs and LAMAs. Along with that, in severe conditions, we use inhaled glucocorticoids, ICS, in third category when the condition becomes severe. And when the condition becomes very severe, then we have to give long-term oxygen therapy or continuous oxygen therapy along with everything else. So these are the common formulations which are used. I have talked about them. Antimicrobials. So these are the antimicrobials. You can just go through them by yourself. Thank you.